So today I'm very fortunate to be speaking with Associate Professor Emmanuelle Schindler, who's based at Yale. So she's a professor of neurology there. She's also medical director of the Headache Center of Excellence, I believe, within the Connecticut Healthcare System. Is that right?
Correct. Yes.
Yeah,
I'm actually mainly based at the VA hospital that's affiliated with Yale.
excellent. Yeah, and I've been a huge fan of your work for some time because you're sort of one of the world leaders in headache disorders broadly and specifically in this sort of interesting, recently re-emerged field, I would say, of the application of serotonergic psychedelics in treating some of these headache disorders. So your work largely has focused on this interesting finding historically, I think dating back to the late 90s, there was this idea amongst a sort of community-based patient group with cluster headaches, which are colloquially known as suicide headaches, that LSD and then eventually psilocybin and other things were extremely effective in treating and sometimes preventing these things. And this led to the formation of this group that I'm sure some people will be familiar with, this nonprofit Cluster Busters, who has been for some years seeking to trial non-hallucinogenic versions of these drugs like 2-bromo LSD or BOL 148. So yeah, could you tell us a little bit about how you got interested in this field?
Sure. And thank you for inviting me to speak. I'm always glad when there's interest in this area. It's sort of a small sliver of the larger pie of psychedelic medicine. So I always had an interest in the brain. I'm going back way back now. And I knew I wanted to go into neurology after studying in med school and doing some rotations. I really enjoyed neurology. I really enjoyed headache disorders because it's something, although within neurology, less so now, but the old adage is diagnose and adios. Can't really do much for your patients in neurology. They often have devastating conditions, but again, that's changing. But for headache, there's actually a lot you can do. And so I really liked how you could really improve someone's quality of life, even with some pretty basic treatments, both pharmacological and non-pharmacological. And then, but I also wanted to go into research. And so I got a PhD as well. And I joined a lab that was the serotonin lab and studied serotonin receptors. And it so happened that we used psychedelics to probe the serotonin
Mm,
2A. We used other compounds to probe the serotonin 2C, dopamine receptors. And so basically, it was sort of mapping out there are some really unique features, some really unique characteristics of the serotonin 2A receptor in terms of how it responds to different ligands. So that was the focus of my PhD. Just so happened that I was using psychedelics to learn about the serotonin 2A receptor. So I gave rabbits LSD and DOI, which is a synthetic phenethylamine compound similar to mescaline in some ways, and comparing how it altered the serotonin 2A receptor, how it altered behavior in rabbits, and we use a classical conditioning model. And I even went so far as to put the LSD directly into the frontal cortex, and so I had a
mm,
lot of fun with that.
mm.
As I was writing my thesis, I came across all the clinical work that was starting to come out, and this was sort of in the 2000 2008 or so time when I was writing up my thesis. And so there was some work coming out, including work in cluster headache. And I thought, well, I like headache and I studied psychedelics. Why not combine the two? And it's fortunate because it's not often that your PhD thesis ends up being something that you carry forward into the future. So so after grad school, finished med school, and looking for neurology residency programs, from my research and my thesis, I found that at Yale there was a Dr. Andrew Sewell who was preparing to work on a study to look at psilocybin in a cluster headache. And so I got in touch with him even before residency, and we started working with the Cluster Busters group in that way with
Mm.
some survey data and gathering information from a survey. And so I first met the Cluster Busters group probably 10 years ago or so. And
Okay.
since then, I've been working. They really provided a lot of key information, really valuable information about
Mm.
how to design the study, what's needed next. And they're really helpful for recruiting patients too.
Hmm.
Unfortunately, Dr. Sewell passed away a year after I got to Yale, but fortunately, his mentor, Dr. Cyril D'Souza, who has a lab where he's been studying cannabinoids and ketamine and other compounds for some time, took a chance on a neurologist who wanted
Mm.
to study headache disorders with a new drug. Yeah.
Well, yeah, that's an amazing story. I didn't realize that your interest went that far back, but I'm glad you're able to continue the work because I think it's definitely one of the sort of more interesting areas of clinical research outside sort of psychiatry with these compounds, in my opinion. I guess some people, wouldn't be aware, effects on vasoconstriction is and other properties of serotonergic agents, goes back all the way to Hoffman and his work with ergolines like LSD and other things. And it's actually a pretty well-known property of many of these drugs. And obviously some of until these CGRP antagonists were developed, a lot of the classical drugs for migraine are triptans, right, that target the 5-HT1 receptor subtypes in various ways, which are also common targets in some cases for various psychedelics. So one of the things I've always been curious about in this field is, what do you think might be going on mechanistically with psychedelics versus, say, triptans? And the follow-up question there is, do you think the sort of psychedelic effects of these drugs are important or maybe less important in fields like neurology and headache disorders as a result?
Well, I'm glad that you pointed out the history with Hoffman and the relationship, the chemical similarity to triptans and others, because that's a very clear reason to think, well, it's not a big surprise that psychedelics would have effects in headache disorders because of how similar they are, both chemically and pharmacologically. The whole vessel constriction thing, it's gone back and forth in terms of whether we really think that vessel constriction is treating a headache condition, or if not having enough vessel constriction is causing it. The term vascular headache is still floating around, but we largely don't only look at vessel constriction. Actually, some of the
Mm.
newer drugs specifically don't constrict blood vessels because that would not be safe in patients who have had a heart attack or a stroke. And so
Right.
some of the newer treatments, including non-pharmacological treatments, like some of the neuromodulation devices, don't constrict blood vessels. And so it would be nice if it was that simple. It's like, oh, it constricts blood vessels just like triptans and just like dihydroergotamine, but that's probably not the whole story. Plus, constricting blood vessels might be in part relevant during a single headache, but the fact that patients, and through studies now, it's reported that taking these drugs can actually
Mm.
turn off a cycle, or can actually give patients, let's say in patients who have cluster headache, who are chronic, who have the headaches year round, give them a break. How that happens can't just be vessel constriction, because it
Yeah.
can't just clamp the vessels down and not ever let them open back up
Mm.
again. So it can't be that simple. There's something else going on. And yes, we can look at what receptors these drugs bind to, and but that's not the whole story either. There's a lot of
Yeah.
off targets that we like to focus on serotonin 2A, but that's, again, it's not clear that that's where the therapeutic effects are coming from. And then your other question about the psychedelic effects. So cluster headache patients have long found that they do not need psychedelic doses in order to get this, preventive effect or the abortive effects either. And they actually don't want the psychedelic effects. It's a lot of
Yeah,
work
that's
to
right.
go through to go through that, especially those who do have the chronic form of cluster headache where they have the attacks year round, or they may have to dose at certain intervals. It's just not possible to
Mm.
do high doses. And so there are also the non-psychedelic compounds, like you mentioned, to Brimo LSD, that is also reported to have effects. And there's some other compounds with reduced psychedelic activity, like DALT, which has been described
Right.
as well. So it does not appear that the psychedelic experience matters
Mm.
in the studies that I've done. Overall, when I'm looking at both cluster and also the migraine studies that I've done, when you look at it, the intensity of the psychedelic experience during dosing does not correlate with the outcome. So how much of a
Oh, right.
reduction in the headache frequency you get over
Yeah.
time.
I find that super fascinating because in psychiatry where, people are using instruments like Madras, and there is that pretty clear correlation on things like the MEQ30 between in subjective intensity of effect and maybe clinical efficacy immediately or in a sort of enduring sense. So yeah, it's great to see that you apparently can decouple the psychedelic effects from the effects of these drugs in headache.
Well, but you're also treating different things. I think when you're
Yeah.
looking at psychedelic medicine, it's not just a monolithic thing. Here's psychedelic medicine, here's how you use it. You are treating different disease, different diseases, and also different patients. There are some patients, like for instance, cluster headache patients, who might need higher doses, not because they need to have the experience. It's just their body needs more of the drug in them to turn off the systems that are generating
Right.
these headaches. And so and as I understand it, again, this is outside my field, but as I understand it, the psychedelic experience is part of the therapy and when treating certain mental health conditions, where that's actually probably helpful for the patient.
Yeah.
Whereas for headache disorders, we're not treating an underlying psychiatric condition, we're treating a headache disorder.
Mm.
And so,
Mm.
and these are all brain diseases. And so,
Yeah.
and patients who have both headaches and a psychiatric condition, treating one may also benefit the other because there's an interplay. But the way that cluster headache patients, again, I use them as the example because that's where the most data are, don't use high doses. They may have to dose at certain intervals depending on how their disease manifests. It's a different
Mm.
protocol than for mental health. So again, you're
Yeah.
treating a disease in a patient, not a singular
Mm.
psychedelic medicine protocol.
Yeah, it's super interesting the sort of bedside to bench reverse translation that's taking place now. And that's how I was sort of introduced to this field most directly, is through a very good friend who'd read online. He'd been suffering cluster headaches for a very long time, had worked with a neurologist to, there's diet and sort of seasonal and hormonal elements to cluster headaches. Basically, by exclusion, had tried essentially everything and got pretty desperate, and had this pretty abortive and then preventative effect of a fairly low dose of DMT, which is what got me
Mhm.
really curious to sort of dig into the science. But you ask anyone with cluster headaches and they'll tell that have had success with psychedelics, and they'll tell you that it's pretty transformative and very different from the existing drugs that are available for these patients.
Mhm. Yeah.
So yeah, it's super exciting.
And then also just to keep in mind that they don't work for everybody either.
Yeah,
I've
of
known
course.
patients to
Yeah.
try all different types, high doses, low doses, and it does nothing for them. So
Yeah.
it's just a bit of a reality check
Yeah.
that it doesn't, it's not for everyone. It's just like any other, medication. We have dozens and dozens of different treatment options in headache medicine, and they don't all work for everybody, and they're not
Mm.
always tolerated by everybody either. So there's
Of
some people
course.
who probably shouldn't come near a psychedelic.
Yeah,
Even if
exactly.
it worked really well for them headache wise, probably should not be taking
Mm.
it. It's
And,
on,
and
I
and
think it,
another sort of motivation for the development of these sort of, non-hallucinogenic agents, maybe in patients that also have a family history of sort of psychosis or other contraindications.
yeah, yeah. So I think not, I don't like, I've, heard the term taking the magic out of magic mushrooms. That's not really, when I mention these, I'm not being a Debbie Downer or party pooper, but it's like, why not treat the drugs like any other drug?
Yeah.
And that way we know what we're dealing with. But I also recognize it's very different. It has a long history with different cultures and a lot of patient research, especially with cluster headache going on. So we can't quite treat it like any other drug. I feel like at some point, yes, when you break down psilocybin versus everything else that's in the mushroom, say,
Mm.
it's important to look at it like you're developing a drug.
Yeah. No, and I appreciate that sort of reality check for sure. It becomes, I guess, another option that hopefully will work for at least some patients through hopefully a fairly sort of rigorous clinical triage of options, which I think is the right way to look at it too, not as a panacea. So approximately how many clinical trials have you run, and with which psychedelics and for which types of headache disorders? Because I know you've been in this field working for quite a while now.
Yeah, so I've only used psilocybin thus far, and I've used the synthetic drug,
Hmm.
and I've used the dose of 10 milligrams or weight-based 10 milligrams per 70 kilograms, but I've now gone to just the 10 milligram
Hmm.
dosing.
Is that a sort
Um,
of perceptually discernible dose in patients? So they report things on the MEQ as being detectable in terms of psychedelic effects?
so it is definitely detectable. And when I started, I've kept with the same. I have used the five-dimensional altered states of consciousness scale.
Right.
So on the total, it pretty much on average it's about 20%. So
Right.
it's about 20% of the maximum.
Okay.
And so yes, it is perceptible. Some patients don't feel all that much. They say they feel like they've had a couple of beers and they fall asleep. And then we have others who do have the more full experience. We've also had a
Interesting.
couple people on placebo have the full experience. So then you got to
Yeah.
tease out the high expectations and everything else. So,
Yeah.
and the 10 milligram dose, it's roughly 1.5 grams of the dried mushroom. And
Mm.
that's roundabout where cluster headache patients will often land in terms of of the dose that they use. And so that's where that came from, that dosing. And I started out in cluster headache, and this clinical trial had two parts. The first part was a round of treatment, the treatment being 3 doses of the 10 milligrams, 5 days apart each. And then for those who still qualified, at least 6 months later, they came back for a second round to see if the first part it was randomized, second part was pseudo blinded, but everybody got psilocybin the second time to see if people responded differently after a second dose, or we could do within comparisons for those who got placebo first. Then I also did a migraine pilot study, and because we don't have the same amount of information from patient experiences with migraine, it was a simpler study. It was a crossover study. It was just a single dose, same dose, where I found a 50% reduction in the migraine frequency in the couple of weeks after psilocybin. I have a second migraine study in press right now that compared single dose versus two doses, sort of coming closer to the sort of pulse treatment that cluster headache patients use. Interestingly, I did not find a difference between one or two doses. So it could be that for migraine, you don't need that same regimen, which to me is not a surprise. Migraine and cluster are two very different animals. And so
Sure.
what is used in cluster may not necessarily be relevant for migraine. So all of these studies are small though, and so I
Mm.
am seeking funding opportunities to do larger scale studies and with different doses, different regimens, different
Mm.
compounds too eventually. But I like to sort of stick with psilocybin for now, just kind of build
Mm.
off of what I have.
Yeah, I think that makes a lot of sense. Within the various sort of limitations that exist, keeping things as systematic as possible, I think is probably the only approach here. And maybe we can wrap up by a discussion with a sort of one of your more recent trials that I saw was announced, which is super interesting to me, given the recent interest in the sort of neuroplastic effects of psychedelics that Alex Kwan and others have shown. I saw that you're running a trial where you will be also looking at synaptic remodeling via a PET imaging arm with the PET tracer for SV2A, this sort of synaptic vesicle protein. Are you able to tell us a little bit more about that study?
Sure, yeah. So this idea came from the growing literature looking directly at the brain now with psychedelics, and it's something that in headache medicine we've been doing as well for some decades. I'm also including functional connectivity as well, and also the measure of the synaptic density. I'm starting out in patients who have migraine just because the way that cluster manifests, the most patients have annual cycles, and the treatment involves 3 doses. It's a little more challenging to see what happens after each dose. That's a lot of PET scans, and that's a lot of money.
Yeah,
So
yeah.
we're starting out in migraine. Eventually, I would like to add cluster as well, but it will be obtaining baseline scans and then 1 week after dosing, see if there are changes and if those changes correlate with the change in headache frequency. I'm also including healthy controls because as of now, there are functional connectivity studies in migraine compared to healthy controls, although it's sort of mixed findings, as one
Yeah.
would expect. SV2A has not been looked at in migraine yet, so that knowing whether there's a difference in migraine patients versus healthy controls will be important to establish
Mm.
first, and then see what changes there are after psilocybin.
Amazing. Yes, it sounds like a lot of really interesting sort of primary findings will fall out of that work for sure. And that's, you mentioned this trial is recruiting at the moment, right?
It is, yes.
Yeah, excellent. Yeah, super exciting work. I think it's been a really fascinating conversation, Emmanuelle. So I appreciate you taking the time for sure. And yeah, wishing you all the best with the studies that are ongoing, both for the sort of basic science and then the clinical research, but also for the patients who will benefit ultimately from all of this work. Thank you very much.
Sure thing. Thank you.